Okay, so we're going to take a look at dysphagia and malnutrition. Again, one of the big Gero syndromes that we really need to stay on top of. We usually assess for it at the bedside, at home, wherever they're eating. We need to really look at that plan. How are we going to keep someone with dysphagia nutritionally balanced as well as hydrated? We really have to look at the differences of anorexia of aging and malnutrition, and we have to describe what we're going to do. How do we assess that older person for malnutrition? And again, looking at that homebound individual, how are they getting what they need? Lab values that you'll look at: albumin. We'll look at body mass index. We look at how are we assessing with the mid-arm circumference and tricep folds, looking at the different types of diets. The term cachexia, this is usually what we call that terminal muscle. It's just they're emaciated, they're very malnourished. So again, knowing that anorexia of aging, which is more the loss of appetite, not the anorexia that we see like in someone with an eating disorder of like anorexia and bulimia. What is amazing is dysphagia is prevalent in up to 30% of hospitalized patients and nearly up to 60% in the nursing homes. And what we know is that there are difficulties swallowing just with increased age. So what this means then is they have greater risk for nutritional deficiencies, which makes them at greater risk for skin integrity issues, which I do have you reading that on your own, but just remember that correlation between nutritional status and skin integrity. And then that increased risk for respiratory problems, especially with aspiration. Dehydration is one of our biggest things. Dehydration will change their electrolytes. Malnutrition and proteins in the diet affect how medications are metabolized and utilized. So we really have to be more in tune to the INO, the daily weight, the proteins, the prealbumins, because many of this just exacerbate their medical problems. Warning signs and risk factors, it's usually related to that neuromuscular impairment. Maybe their tongue can't move like it should to move the food around. The pharynx, we get a loosening of that upper esophageal sphincter. We look at any coughing or choking with swallowing because maybe they can't handle thin liquids but can handle it a little bit thicker. They have difficulty initiating or even getting that to swallow. Food sticking in their throat, unexplained weight loss, loss of saliva, changes in their dietary habits. See this a lot with if you can't swallow, you just don't want to eat at all, you're afraid. The recurrent pneumonias with no real trigger, no chronic respiratory condition that predisposes them to be more at risk for pneumonia. And they're getting pneumonia, they're probably what we call silently aspirating. Worried about that wet voice changes, a lot of nasal regurgitation. So it really is a lot more than just if they cough or choke when swallowing. It just, inconsistency among people that are assisting to eat or doing the assessment really helps. Other warning signs that we see with esophageal dysphagia, these are motility issues, neuromuscular problems. It is not uncommon with some cancers for that esophagus to obstruct. It narrows, and they need to actually have the esophagus dilated because that food will just get choked. So it interferes with how does that go from that bolus from the esophagus into the stomach. That person then feels like things are sticking in their throat or in their chest. They can have oral pharyngeal regurgitation, so that risk for aspiration is even higher. And again, changes in dietary habits, because if it hurts or I feel like I'm choking, I'm not going to eat it. And again, talking about that recurrent pneumonia. The clinical evaluation done is usually done by a speech therapist. And as the nurse, we want to understand conditions that can predispose them or who complain. And these people, usually through that history, they're finding that up to 80% can be diagnosed just through their history of their subjective comments to us, which can become very difficult when you have a person that has cognition changes. So it's imperative as we're delegating to the CNAs or to make family aware if they're helping with feeding, that you need to be notified of subtle changes. And again, we have to look at cognition, neuromuscular problems, respiratory assessment, as well as medications, because some medications can affect motility. So we want to know that we're taking everything into consideration. But that history is going to be really big. So what are we going to do about it? Well, we can see that they do some compensatory eating techniques, which is important. Maybe teaching the person to double swallow. Put them on a dysphasic diet, specifically looking at thickened liquids. Definitely oral hygiene. If people are having difficulty swallowing, they can pocket food, especially if they've had a stroke. We want to be able to assist with the appropriate adaptive equipment, and here's where occupational therapy and physical therapy can come assist you. They may need to go to enteral feeding where they actually just have a peg tube placed, and this is not uncommon for some people because of the swallowing difficulties. We'll have a peg tube placed, but still eat a little bit for the social enjoyment, sit at the table, but they may need both. This can become a big issue if somebody does have a enteral feeding placed, and then as they hit end of life or in a hospice situation, when do you stop feeding? Because these people, as the body slows down, are also at risk for aspiration if that stomach isn't going to utilize and empty out like it should. And then now we know we have many drugs and treatment options that we can do to manage the gastroesophageal reflux. So identifying that earlier in our younger adult years really helps prevent some of these problems in later adult years, especially with that reflux and we get the acid erosion. Anorexia, again, is just that I am not hungry, I don't feel like eating, and this is a natural part of a process that occurs in age, but with that becomes a risk for malnutrition and weight loss. And this becomes very difficult when working with the older population, with family, especially more so when it is a male that's affected, because he had been robust, he ate all the time, and now he's just not hungry. And people try to bring in their favorite foods, and that's not so bad, but we also don't want them filling up on sweets because that's what their tastes are still craving. Sarcopenia is what we call progressive and generalized loss of skeletal mass and strength. This is seen with malnutrition. They're just much weaker, which now they're at risk for falling, because if they go to lift something or themselves, they can try to compensate and fall. The cachexia is what we see with terminal illness. It's just a significant muscle wasting. Most often you can see this very much in their face. It's like their temporal area is now hollowed out. It's just that specific look of extreme sarcopenia and cachexia. And again, falls in your skin integrity. This just leads to a multitude of problems. And here they are. So with malnutrition, again, wound healing, you don't have that albumin and pre-albumin. Your skin is more at risk for pressure ulcers. You're definitely at greater susceptibility for infection. You won't recover well if you have an acute illness. So these are our COPD, CHF clients that if already malnourished, don't heal real well. That's sarcopenia, or losing that lean body mass and muscle strength, and they are tired. They are so tired. And again, gait balance. These are your risks for falls and fractures. And because of that malnourished state, um, their prognosis is very poor. Social factors are probably one of the bigger issues why we have nutritional risks in our elderly, and it's something very important as far as the Gero syndromes to assess. Um, Many people don't want to cook for one. They're lonely, they don't have the money, or they're dependent on other people to get their food. So you really have to do that history, as we'll talk about. Psychologically, many people with depression don't eat, although some are like me, and when depressed, do eat. When people are real anxious, food is not the first thing they're thinking of. It's more that protective fight or flight mechanism when people are in an anxiety state. Dementia people just forget to eat. They're just not, unless they're really triggering, they're hungry, and even then they sometimes can't connect to get food with that feeling of hunger. Those in a bereaved state, the loss of a partner, trying to eat for one, going out to eat alone. Again, these are such big factors that we really have to know our client's history, both medically, socially, and spiritually. Biologically, factors that can continue, that do influence. We really have to worry about teeth. Dentures are expensive. If people, again, are losing weight, their dentures won't fit as well or they hurt. So people need to change foods because they don't have their teeth anymore. They may, with aging, we know they lose their taste and their smell, which is so obvious. If you've ever been in an elevator with a group of elder women, you can't breathe because they can't smell their perfume, but yet put it on by the gallon. A lot of GI intestinal motility disorders, or if they have underlying Crohn's disease. Muscle weaknesses, can't get the food down, very dry mouth, losing that sense of smell, that olfaction. Renal disease, diets, renal and liver disease, we start worrying about proteins and the body's ability to metabolize them. Just a physical disability and they can't cook. People with end-stage COPD are too short of breath to breathe. There are many drugs that make people feel a little nauseous anyway, and then that, again, decreases their desire to want to eat. There are many screening tools out there, and I put some out in the learning plan for you. We look at clinical screening tools as well as the ability to make food. A little bit more advanced than we need to do, but that measuring body mass circumference, BMIs, circumference of their arms, looking at the laboratory tests of albumin and pre-albumin, looking at that full clinical data review, the medical history, drugs that they're on, and again, their diet review, which is very different. We want them in the last week. Tell me what your average week is like. Who cooks your food? How do you get your food from the grocery store? So it is much different. Evidence-based strategies. Dietary supplements are only when there's symptomatic nutritional deficiency because we don't want them filling up on taking pills. The idea is real food when possible, which does include protein shakes, okay? We really, again, if you're going to have small, frequent meals, what is it that you're eating? The USDA My Plate method shows ideal portion size while we're focusing more on malnutrition during this unit. And again, get the other members of the team involved. They will be there for you. So in summary of the Gero syndrome of malnutrition, they're multifaceted and complex. You have to look at mind, spirit, body when it comes to this. You need to use, if you are measuring, you want those two anthropometric done correctly, specific lab values. Again, that albumin and pre-albumin will be your best indicators. And whenever reversible, we need to reverse it. We need to use evidence-based practice, and we also need to refer to other disciplines. Social services, nutritionalists, speech therapist, occupational therapy. So as you can see, even nutrition is multifaceted and not just from nursing.